Hello, my name is Christina and welcome to my presentation. Did you know that heart failure currently affects 38 million people worldwide, and in Australia 1.6% of all hospitalization during 2015 and 16 were related to this condition? Today, I will draw on the case study of Mrs. Brown and her acute exacerbation of chronic heart failure, present the clinical manifestation found, and explain the pathogenesis causing the clinical manifestation. Patients suffering from acute exacerbation of chronic heart failure present with clinical manifestation of dyspnea, tachypnea, tachycardia, hypertension, presence of basal crackles in both lungs, and decreased oxygen saturation level as seen in Mrs. Brown. Normal cardiovascular homeostasis become progressively difficult to maintain during chronic heart failure because of underlying conditions and overactive compensatory mechanism. A decrease in heart function and ventricular remodeling activates the compensatory mechanism to stimulate the sympathetic nervous system response, renin-angiotensin-aldosterone system, and the neurohormonal response to increase cardiac output and maintain normal tissue perfusion. Dyspnea is a sensation of shortness of breath. It occurs in left heart failure when pulmonary congestion reduces lung compliance. Mrs. Brown is experiencing severe dyspnea due to pulmonary edema caused by ventricular remodeling and mitral regurgitation. Mitral regurgitation is the backflow of blood from the left ventricle to the left atrium during ventricular contraction. Occurs due to mitral valve abnormalities and increased end diastolic pressure. In systolic dysfunction, when the left ventricle is unable to fully empty because of inadequate ventricular contractility during systole, it will result in an increased end diastolic volume that backflows into the left atrium. As a result, there is an increase within the cardiac volume and an increased hydrostatic pressure in the left atrial pulmonary veins and pulmonary capillaries, which cause fluid congestion in the lungs that ultimately impair gas exchange. Over time, an increase in preload volume and an increase in diastolic pressure produce changes in the structure of the ventricle, such as an increased ventricular dilation and ventricular hypertrophy that affect to exacerbate systolic dysfunction. As congestion increases within the lungs, the alveolar ventilation and pulmonary capillary flow will become impaired and cause decreased levels of oxygenated blood returning to the heart. As a result, there is a ventilation perfusion mismatch, and this is clinically observed in Mrs. Brown's decreased oxygen saturation level. Additionally, as gas exchange becomes impaired because of fluid buildup in the lungs, an increased level of carbon dioxide develop. When increased level of carbon dioxide are detected by chemoreceptors located in the carotid and aortic arteries, the body will compensate by activating the sympathetic nervous system to regulate the respiratory rate and depth until the excess carbon dioxide is eliminated. For this reason, Mrs. Brown's presentation of tachypnea is compensatory mechanism to impaired internal respiration and gas exchange. Furthermore, Mrs. Brown's clinical manifestation of hypertension results from decreased blood flow to the kidneys. As the heart fails to maintain adequate cardiac output, the compensatory mechanism activates the renin-angiotensin-aldosterone system as an attempt to increase blood flow by retaining fluid. A reduced blood flow to the kidney activates juxtaglomerular cell in the kidneys to release renin. Renin converts protein angiotensinogen to angiotensin 1. Angiotensin 1 is activated by angiotensin converting enzyme in the lungs to become angiotensin 2. Angiotensin 2 triggers real vascular receptors to vasoconstrict the systemic arterial system, resulting in increased level in blood pressure. Angiotensin 2 also triggers the release of aldosterone from the adrenal gland. Aldosterone works at the distal convoluted tubule in the kidneys to retain sodium. As a result, there is an increase in extracellular volume, which in turn increase the venous return to the heart, thereby raising the stroke volume, cardiac output, and arterial blood pressure. However, during heart failure, the compensatory mechanism of RAS leads to fluid overload that results in chronic hypertension, which ensues further damage to the heart. Finally, Mrs. Brown's manifestation of tachycardia occurs because of reduced blood volume within the ventricular during end of diastole and is caused by irregular ventricular rhythm, atrial fibrillation. Irregular rhythm occurs because of atrial fibrosis and loss of atrial muscle mass. When atrial fibrillation occurs, rapid chaotic impulses are conducted to the ventricle, increasing heart rate and reducing end diastole volume and effectively reducing cardiac output volume. The changes in the end of this diastole volume results from a decrease in the duration of ventricular diastole. The changes in the duration occurs when the compensatory mechanism activates the SNC to respond to decreased arterial pressure. As a result, there is an increase in the strength of ventricular contraction and an increase in ventricular rate, which effectively reduces the duration of ventricular diastole. However, because of structural changes to the heart, the cycle of uncoordinated arterial electrical activity continues to activate the compensatory mechanism, and the cycle of low cardiac output and increased heart rate will continue to negatively affect heart functions. Thank you. That concludes my presentation. Thank you.